Good morning. I'm John Bitson, the Menard Family Director of the Sheila and Robert Challey Institute for Global Innovation and Growth. Welcome to the Human Progress and Flourishing Workshop. In this series, we bring scholars from across the country to present insights from their research and experience with the NDSU community. Topics focus on innovation, opportunity, and ways to increase individual and societal flourishing. I'm excited about today's topic. We're going to be talking about healthcare. And as Michael's going to show us, where we all know that the healthcare market, the problem is that it's too much of a free market, right? And so that's why the costs are high and the quality is low. He's going to, in fact, show us that that's not the case. So Michael F. Cannon is, and I'm excited, so thanks for coming here, Michael. Michael F. Cannon is the Cato Institute's Director of Health Policy Studies. His scholarship spans public health, regulation of clinicians, medical facilities, pharmaceuticals, and medical devices, employer-sponsored and other private health insurance, Medicare, Medicaid, CHIP, the Veterans Health Administration, medical malpractice litigation, administrative law, international health systems, political philosophy, and more. That's it? Okay. And then Cannon is an influential healthcare wonk, according to the Washington Post, and the most famous libertarian healthcare scholar, according to the Washington Examiner. Washingtonian magazine named Cannon one of Washington, D.C.'s most influential people in 2021, 2022, 2023, and 2024. Cannon has appeared on ABC, Al Jazeera, BBC, CBS, CNN, CNBC, C-SPAN, Fox News, NPR, and other broadcast media. His articles have appeared in the Wall Street Journal, the New York Times, USA Today, the Washington Post, the Los Angeles Times, SCOTUSBlog, Forum for Health, Economics, and Policy, JAMA Internal Medicine, Health Matrix, Journal of Law Medicine, Harvard Health Policy Review, the Yale Journal of Health Policy, Law, and Ethics, the Journal of Health Politics, Policy, and Law, and Quinnipiac Health Law Journal. His latest book is Recovery, A Guide to Reforming the U.S. Health Sector. So if you haven't gotten a copy, there's a copy for everybody out there. And Cannon was previously a domestic policy analyst for the U.S. Senate Republican Policy Committee, where he advised the Senate leadership on health, education, labor, welfare, and the Second Amendment. He is a member of the Board of Advisors of Harvard Health Policy Review and the Federalist Society Regulatory Transparency Project's FDA and Health Working Group. Cannon holds an MA in economics, a JM in law and economics from George Mason University, and a BA in American government from the University of Virginia. So as you can tell, he's very well qualified, has published in many places. Super excited. Thanks for making the trip here through Albuquerque, actually, I think, to come here and then going to South Dakota. So thanks, and let's all welcome Michael Cannon.
Thank you so much, John. Thank you, John and Tate and the Challey Institute for having me here. Thank you all for coming to discuss this very important topic. And I'm sorry about the length of that bio. You get old and your bio just gets longer and longer. And so I'm going to be touching on today a lot of different aspects of healthcare. But I keep coming back to something that happened in my office. Well, two things that happened to me recently in my office and in my work. One of them was the Cato Institute, we have an internship program. I've been there 21 years now. I've got so many former interns, I had to create a Facebook group and ask them all to join just so I could keep track of them. And see where they've gone. But I was sitting in my office recently when not just one, but 3 interns came to my door. And it was clear that 2 of them were sort of encouraging the 3rd one to talk to me. Like, it's okay, you know, he won't bite. Go ahead, ask him. The 3rd one was a young woman, Chinese national. Her English was not great, but it was a lot better than my Mandarin. And she came to me and she was nervous and she handed me a few pieces of paper. It turned out that they were medical bills from an emergency room that she visited after an automobile accident that she didn't cause, but she was in, and her car got banged up and she got banged up. So an ambulance came and took her to the emergency department, the nearest emergency department, and they scanned every inch of her. The good news is that she's fine. They didn't find any injuries beyond bruises. And the bad news is that the nearest emergency room to which they took her was in the United States. That's bad news because if you've ever been to an emergency room in the United States and gotten the bill, it might have struck terror into your hearts. She handed me this bill that said that the bill said that the total charges for her brief trip to the emergency room and just a couple of scans from the CT scanner cost her, the total charges were $50,000. $50,000 for a young college student who's here in the United States for the first time and only for a short time, and has never seen probably any bill that size, much less a medical bill, because there is no part of the world, no other part of the world where medical bills are as high as they are in the United States. And a lot of people will look at the US health sector and they ask, why is this the case? The conclusion that most people reach is, well, the reason that people are charging such high medical bills in the emergency room and elsewhere in the hospital and throughout the US health sector is because in the United States, unlike many other countries, government doesn't directly regulate prices for medical goods and services by capping them. It actually does in some places, but generally speaking, it doesn't impose binding price ceilings on medical prices the way that a lot of other countries do. Healthcare providers in the United States have the freedom to charge whatever they want. And that's what you'll hear from people who will defend the sort of outrageous, and I would say even unethical prices that a lot of hospitals will charge will charge a lot of low-income people for emergency room care and other care. They will say, hey, you know what? The hospital has a right to charge whatever the market will bear. And I certainly agree with that. I think that hospitals should have the freedom to charge whatever they want, and people should have the freedom to say no to those prices and choose lower-cost providers. But what's happening, and so a lot of people will then draw the conclusion, well, if hospitals have the freedom to charge whatever they want, and this young woman is terrified because and people around the United States are terrified when they get these outrageously high bills because hospitals are charging whatever they want, then clearly this is an example of market failure. This is an example, an example of how markets do a terrible job at managing healthcare. Because when you give people that sort of freedom, this is what happens. I want to give you some reason today to think, or some reasons why to think that that's not what markets produce in healthcare. And those sorts of outcomes that we're seeing are the result of other forces rather than just the freedom to set prices and the freedom to make your own choices and have markets allocate healthcare resources. The other thing that, the good news, silver lining, it's not really a silver lining, but the bad news isn't as bad as that $50,000 bill makes it seem. The $50,000 charge was the list price that the hospital was charging her. And by the way, that didn't include the physicians or the ambulance, so she was getting additional bills on top of that one. The good part of the bad news is that she does have insurance, and the insurance negotiated those prices down from $50,000 so that her out-of-pocket exposure, the bill said, was only about $5,000 for the emergency room. Again, the ambulance and the physician fees might be more, so they're not coming after her for $50,000. The hospital isn't. That's a good thing. And what I walked through with her were ways that she could try to get that $5,000 down even further, and then do the same with the ambulance company, the same with the physicians. But just the idea that people are having to do this in healthcare, whereas we generally don't have to do this in other sectors of the economy, is vaguely horrifying and something that I'll be addressing. The other episode that came up recently was one I was participating in a call-in show, and I heard from one of the callers on this call-in show was a single mother of 3 in New Jersey. And she was talking about, we were talking about a government program that provides health care to people like her with low incomes, and how Congress is considering changes to that program and how they might affect her. And she was talking about how hard it is to be a single mother of 3 who's struggling to keep the kids clothed and fed, get food on the table, struggling to make sure that they get the education that they need, and struggling to make sure that they have access to the health care that they need in an environment where we tie health care to jobs, and you can, or health insurance to jobs, and you can lose your health insurance when you change jobs. And there are different government programs with different rules about qualifying, and then what kind of health insurance and care you get after that. And her main concern was about how Congress might change this government program that's providing her assistance. But what struck me about her story as she was telling it is that she isn't even aware. It makes perfect sense to me that she's totally focused on this government program and wanting that program to be there so that she can provide health care for her children. But what struck me about it is that she is completely unaware of all sorts of other things that the government does that makes it harder for her to not just to afford health care, in addition to put food on the table and keep her kids clothed, but to afford health insurance and medical care for her children. And so I'm going to be talking about some of those things today as well. And I'm going to start, so I wanted to start by giving you an overview of what my remarks are going to cover. First, I want to talk about what happens really in markets when you leave markets to allocate healthcare resources. If you respect people's right to make their own health decisions, I agree with Bernie Sanders about this much. Every one of us has rights when it comes to our healthcare. And our most important healthcare right is the right to make our own health decisions. And so first I want to talk about what happens when the government just respects that right. When the government stays out of it and lets people make their own health decisions, including lets people enter into healthcare markets, producers enter into healthcare markets to try to provide consumers with something better than what they're getting right now. What do markets deliver under those circumstances? And maybe a little bit about how government intervenes and what happens. And then I want to talk about this idea that what we have here in the United States is a free market in healthcare. Certainly the hospitals can charge whatever they want. That's abundantly clear. But I want to challenge this because this really is a myth that what we have and the outcome, what we have is a free market, and the outcomes that we're seeing are what markets produce in healthcare. Then I want to just give the very briefest of sketches about how we might fix this situation, the situation we're in the United States right now, to make healthcare more universal. Because I think whether you're left or right or libertarian, as I am, everybody wants healthcare to be more universal. We may disagree about the wisdom of having government try to pursue that goal and what government produces when it tries to pursue that goal. But I think we all share that ultimate goal, and we're really just arguing not about whether universal health care is a good thing, but how to get there. So a very brief sketch about how to get there, and then also just a little bit of information about why this stuff is so hard, about why reforming healthcare is so hard. So let's dive right in. So at the Cato Institute, we have an entire project that we call Human Progress. And the goal of this project is just to remind people about how much better life is getting every day on so many dimensions. How much better life is now than it was 50 years ago, 100 years ago, 200 years ago. And one of the ways that, and this is very compatible with the Challey Institute's mission, so I had to throw some human progress data up here, is one of the ways that life has gotten better, or one of the ways that my colleagues have come up to measure how much life has gotten better, is they said, okay, let's look at how much of various goods and services an unskilled worker or a blue-collar worker is able to buy with a fixed unit of their time, so a fixed amount of their labor. Think of it as a minute, think of it as an hour, a day, a week, whatever. And then how much are they able to buy of all of these different commodities with that unit of their labor? And up there, I'm not sure if it's clear for you, but we've got things like barley, beef, coal, cocoa, coffee, copper, corn, cotton, gold, hides, which I believe to be leather. We've got rice, sugar, tea, tobacco, wheat up there. How much was the average unskilled worker, how much tea, how much sugar, how much wheat or cotton was the average unskilled worker able to buy with an hour of their labor back in the 1800s versus today? And what you find is that their ability, the growth in abundance was not all that great up until the beginning of the last century. But after that, abundance began to explode. The average worker, even those who don't have any skills, was able to afford so much more of all of these items. They're able to purchase so much more of these items with just 1 hour of their labor that that even unskilled, low-wage workers are vastly more wealthy than their counterparts from 100 or 200 years ago. What you might think of as the purchasing power for things like sugar or, very important for me, tea, has increased by 10,000% or 5,000%. The amount of sugar, the amount of wheat that a worker is able to buy with 1 hour of their labor has increased by something on the order of 5,000%. That means that food is becoming more abundant. More people can afford the basic necessities that they need to live. This is why, as a result of this sort of abundance, we are now able to keep about 8 billion people alive on the planet at one time right now. That's something humans have never been able to do before. And how is it that we've been able to achieve this? It hasn't been through government regulation and government regulators telling farmers and whatever, hey, you know, make more food, make it cheaper. It hasn't been through subsidies that help people buy food, although subsidies do exist for people who still have a hard time affording food and other basic necessities. The way this explosion in abundance happened was through innovations in the production and distribution of all of these commodities, as well as increases in worker productivity. Innovations in the production and distribution of all of these commodities aided by markets. Markets that left people free to introduce new ways to innovate and find new ways to make food more cheaply, make it last longer, and distribute it around the world at a lower cost so that people can buy more and more of it with each hour of their, with a given hour or unit of labor. This is how humanity, this is making food more universal, so universal that we're keeping 8 billion people alive right now, something humans have never achieved before. And what's enabling it is markets, is relatively free entry, relatively free trade between nations, because when you allow market forces to work, that's what it produces in all of these areas. Where there's a very troubling trend here in the United States that's curtailing that market process that makes all of these items, that makes these items more abundant. The United States is imposing a lot of tariffs on a lot of, maybe even some of these products, and that is going to reduce abundance, but that's maybe a subject for another talk. Now, this is the process that we need to set in motion if we want to make healthcare more affordable. We need to be driving down the per unit costs of delivering the health outcomes and other outcomes that we want the people want the health sector of the economy to produce. And I want to give you some reason for hope about that the same principles that have driven down the prices of all of these commodities can do the same for healthcare. So there is a series of experiments that a number of insurance companies did with the help of economists who wanted to make sure they measured it properly, into what happens when you use a market mechanism to try to drive down prices. So in California, there's a series of experiments. Some of them happened in California with the California public employee retirement system. This is the system that, the part of the California government that buys health insurance for state workers. So this isn't like a regulator sort of thing, it's just government as purchaser. The insurance companies that participated in this program that provided health insurance to state workers noticed something about the prices for all sorts of goods and services, medical goods and services. You see them up there, MRIs, CT scans, lab tests, hip and knee replacements. They noticed that the prices varied widely across the state of California without any relation to quality. There was no discernible relationship between these wildly varying prices and quality. The prices varied so much that hospitals in some parts of California were charging $12,000 for hip and knee replacements. And in other parts of California, the hospitals were charging $60,000 for hip and knee replacement, reminiscent of that $50,000 charge that my colleague at the Cato Institute received. And try though they might, the insurance companies could not get these $60,000 hospitals to lower their prices. With all of their vaunted purchasing power, these major monster health insurance companies like Aetna couldn't get those prices down. I could talk about why, maybe in Q&A if you're curious. But they struck upon a way, an idea they thought might get the prices down. And the idea was to use the market mechanism of consumer price sensitivity. See, the insurance companies, they were basically paying the entirety of the bill, and the consumers were not very price sensitive. If the insurance company is paying the entirety of the bill, whether it's $12,000 or $60,000, the consumer doesn't care. They do care if you try to tell them this hospital over here is not going to be in your network, especially if it's the only one in town. But they don't care how much the insurance company is paying, because the savings, even if the insurance company negotiates a lower price, the savings are not salient to the consumer. They're not going to see it in their lower premiums. Their employer pays the premiums. So what these insurance companies did is they said, look, if you're going to get a hip or a knee replacement, you can go, we're going to make a change. You can go to any hospital you want in the state. Doesn't matter to us. No network restrictions or anything like that. But we're going to pay $30,000 no matter where you go. We'll pay that much. If they charge less, we'll pay less, but we'll pay up to $30,000. And if the hospital you choose charges more than $30,000, you're on the hook for 100% of the balance. That means the consumers were price sensitive, 100% price sensitive at the margin, because they were paying 100% of the marginal cost for these services. And then 90% of the practice of economics is asking, and then what happened? And then what happened? Well, once they made the consumers price sensitive, a lot of things happened that aren't supposed to happen in healthcare markets, because markets don't work in healthcare, or so I've heard. The first thing that happened was consumers said, wow, I don't want to pay a lot for this knee replacement. I'm going to ask my hospital how much they're going to charge me. That's the first thing that happened. Consumers started demanding price information in ways that they didn't before. And then what happened? Well, you know how prices are opaque in the healthcare sector? The doctor doesn't even know what the price is that he's going to charge you. The hospitals don't want to tell you the price either, but the second thing that happened was they began telling the consumers, giving consumers the price information that they wanted, because the consumer said, I'm going to go someplace else if you don't. So consumers started demanding price information, producers started providing it. And then another thing that's not supposed to happen in healthcare, because markets don't work in healthcare, the consumers looked at that price information and said, whoa, thank you very much, I'm going to be choosing this hospital over here. 1/6 of the market, 1/6 of the patients getting hip and knee replacements switched from high-price hospitals to low-price hospitals. That is a huge chunk of the market. They did it because they were price sensitive. They weren't doing that before. They weren't choosing the low-cost hospitals before. They would have complained if their insurance company made them go to the low-cost hospitals before. But they changed behavior to the low-cost hospitals, and that 1/6 shift in market share was enough for the fourth thing to happen that isn't supposed to happen in healthcare markets, because markets don't work in healthcare. The high-price hospitals reduced their prices. They reduced their prices by 37% over a 2-year period, which is a dramatic reduction. You almost never see those sorts of price reductions at all in healthcare, certainly not of that magnitude. The average reduction was about 19.6%, but among the high-price hospitals, it was 37%. That's $16,000 per procedure that they just locked right off of that price just by making the consumers price sensitive. And that is the same result that the insurance companies got and the employers who implemented that, what we call reference pricing strategy or whatever you want to call that, that insurance benefit design that makes consumers price sensitive. When insurers made consumers price sensitive for all of these services, the exact same things happened. The exact four market dynamics that I described happened, and prices plummeted for all these services below two things about these price reductions: below the best prices that the insurance companies were able to negotiate, and the prices fell without anyone having to forego any services. No one missed out on a hip or knee replacement because of this. Consumers just got the prices down, which brought down the cost of health insurance and probably boosted cash wages for a lot of workers. If we want to make healthcare more abundant, like we've made sugar and tea and wheat and cotton more abundant, we need this process. If you care about universal healthcare, this chart should be your obsession. Getting prices down like this is the most important thing that we can do to make healthcare more universal. Why? Because when prices fall for medical care and health insurance, when the things that health insurance pay for become more affordable, then more people can afford to provide health care for themselves and purchase health insurance for themselves. And the rest of us not only have an easier time providing health care for those who still can't afford it, because there's fewer of them. As long as prices keep falling, as long as we keep using this market dynamic, that share of the population that can't afford medical care for themselves gets smaller and smaller and smaller a lot of the time. So not only is it easier to provide medical care for those who can't provide for themselves, but it's also cheaper for the rest of us. I mean, it's a smaller number of people, the prices to provide them health care are lower, and we have more money left over because we're not paying these ridiculous exorbitant prices, almost extortionate prices in some cases. That healthcare providers are charging nowadays. It's not just, and this doesn't just happen in services like this. It happens in with prices for prescription drugs. These data are about 20 years old, but I love this chart because the government produced it. The FDA looked at pricing data for pharmaceuticals when what happens to prices for a drug when the first generic enters the market to compete with it, and then when the second generic enters the market to compete with it, and then the third, and you can see what happens here. Prices fall. The more competition you get, so it works. It works in the market for pharmaceuticals. It also works across the board. Markets may drive down prices and make healthcare more universal and affordable, as a matter of course, across the board in healthcare. And this chart kind of illustrates, these charts kind of illustrate how that happens. I'm not sure, are you able to see the x-axis labels here? You can probably see the titles. Yeah, okay, no, not seeing the x-axis labels. But what we have here are different categories of clinicians within emergent care and dental care. I've also got two similar charts for mental health care and primary care. And what these charts show is, all the way on the right, you've got your highest trained specialists. You've got your trauma surgeons for emergency care. You've got your oral surgeons for dentistry. And then as we move left across the x-axis, we've got lesser and lesser trained clinicians. So we go from oral surgeon to dentist, dental therapist, hygienist, and dental assistant. And over here, trauma surgeon, emergency physician, nurse practitioners, registered nurses, paramedics, EMTs, and orderlies. And what these charts, the blue bars, show is the average hourly wage for each of these professions. It's highest for the highest trained ones because they've got the most skills, they've got the most student loan debt to pay off, so they charge higher prices. And what markets do to make healthcare more affordable is, as a matter of course, they push the delivery of services down to the lowest cost provider who can offer you that service, consistent with quality service. So, as a matter of course, markets will offer you options for primary care or for emergent care where you don't have to see a trauma surgeon for every cut, or every time you need something stitched up. You can see an ER doc or even a nurse practitioner who can take care of that. When it comes to dental care, we don't have everyone go to see an oral surgeon for routine cleanings. You don't even need to see a dentist for routine cleanings. For that, we have dental hygienists. They're much more affordable. They make dental care more universal. The doctor comes in, or the dentist comes in at the end and has a look and makes sure, but oftentimes you probably don't even need the dentist there at all. And it's a good thing we have that option of dental hygienists, because otherwise a lot of people would not be able to afford routine dental care. So markets provide this to consumers, these lower cost options, because that's what consumers want. But it often doesn't work out that way because regulation prevents that market process from making medical care more affordable for people. And here I'm thinking about the single mother from New Jersey and how hard it is for her to get basic primary care or dental care for her kids. So how does the market interrupt this process? Well, in a lot of states, it is unlawful for nurse practitioners to practice independently of physicians, to practice on their own. Either hang out a shingle, create a primary care clinic or an urgent care clinic that's staffed entirely by nurse practitioners, or buy a van and go around and provide roving primary care to people in low-income neighborhoods. A lot of states make it unlawful for them to do that. Why? The ostensible reason is quality. They want to make sure that the government wants to make sure that people are getting the highest quality care available. But when you look at who lobbies for these regulations and what happens when you suspend them, a different picture emerges. The people who lobby for those regulations are not the consumers who are going to the government saying, please protect us from low quality nurse practitioners. It's the physician with whom the nurse practitioners are competing who go to the legislature and say, oh no, quality, we can't let these people compete with us to provide low cost primary care because of quality. But what happens when you suspend those regulations? Well, we have, sort of a natural experiment that occurred during COVID. When COVID happened and the hospitals were slammed and there were shortage conditions in hot spots across the country, a lot of states realized, hey, these sorts of regulations that we're imposing on mid-level clinicians are blocking access to care for people. So they suspended a lot of these regulations. They allowed nurse practitioners to practice independently. They allowed clinicians from other states to come in and provide health care in their state, even though they didn't have a license from that state, so that's generally unlawful. And then what happened? Well, a lot of people got a lot of medical care, quality medical care from out-of-state clinicians, from lower-trained clinicians, and there was no apparent harm. There was no apparent harm. We've looked for any horror stories of people getting getting harmed by nurse practitioners or other mid-level clinicians who suddenly had more freedom to provide more services to more people, and we can't find any. And we're pretty sure that if there were any, the physician lobby that wanted these regulations in the first place would have found it. But what ended up happening was states reinstated a lot of those regulations after a couple of years, even though there was no evidence of harm from suspending them. And so you can't really argue, you can't really argue that these regulations are about promoting quality, because when we got rid of them, quality didn't suffer. I think the explanation that makes a lot more sense is that the physician lobby and the dentist lobby don't want the competition don't want to face the competition that markets just provide as a matter of course as a way to make healthcare more universal. Dental therapists are actually a really interesting example. Raise your hand if you've ever heard of dental therapists. You're probably from Minnesota. Minnesota is one of the few states that allows dental therapists to practice. So dental therapists is just something in between a hygienist and a dentist. They have more training than one, less than the other. They can do a routine cleaning, of course, but they can also do simple procedures like fillings and extractions, and they do it more cheaply than a dentist does. this clinician category, this profession, this specialty emerged the same way all these others did, through market forces. People just said, hey, we see a need, let's fill it by giving people just enough training so that they're competent to do cleanings, routine extractions, and routine fillings, but not so much that they're going to be as expensive as a dentist. And so some innovators came up with the new clinician category. They came up with the training, the education and training programs necessary to create these new health professionals. And then but in order for them to practice medicine or to practice dentistry, they had to get permission from state governments. And when they tried to do that, who showed up to say, no, you should not be able to do that? The dentists did. And it's only in a few states that they have broken through, that this market process and these market forces have been able to break through by getting the legislature to recognize these licenses, that dental therapists have been able to practice and make basic dental care more affordable for more people, in particular low-income people. And so that process that market process of creating new clinician categories that make quality medical care more affordable is something government is interrupting all the time, and it happens also in mental health care and primary care. For example, we published a paper recently at the Cato Institute about how states prohibit clinical psychologists from prescribing medications, but allow primary care docs to prescribe psychotropic medications, even though the clinical psychologists know more about these drugs than the physicians do, and how that makes no sense. But because the clinical psychologists cannot prescribe, patients have to go either to a primary care doc who doesn't really know what they're doing and just taking the advice of a clinical psychologist, or they can wait to see a psychiatrist, which is a mental health provider who is a physician and can prescribe these drugs, but who is also very expensive, and there are often long waits to get in to see them. Again, we've got regulations that are blocking the market process that would otherwise make healthcare more universal as a matter of course. And one of the most exciting developments out there, from my perspective, about how markets can make healthcare more universal is coming in the area of information technology and AI. This is the abstract from a study. It was a small study. We'll have to see if it replicates. But a study that said, hey, we're going to see how accurate physician diagnoses are when we give them some standardized patient profiles and ask them to make a diagnosis when they're working by themselves to make that diagnosis. And then we're going to give the physicians this AI tool, different physicians this AI tool, randomly assign them, and then we're going to see if the physicians with the AI tool do more accurate diagnoses than the physicians who don't have access to it. And then just for fun, because the AI is already there and it'd be totally cheap to do it, we're going to let the AI do the diagnoses by itself without any physician involvement. And what happened in this study? Well, it turns out that relative to the physicians who didn't have the AI, the physicians who did have the AI tools, there was a difference of about 2 percentage points, but it wasn't statistically significant, which means we can't be sure that the AI improved the physician's diagnoses at all. But you know what was really interesting about that study? Over here, in the no physician group, the AI was 16% more accurate than the physicians were. That suggests that physicians are human; they make mistakes. Humans program AI tools; they also make mistakes. But it's not a game. We don't need perfection in here. Perfection is not possible. This study suggests that at some point the AI, may already be at the point where the AI is better at doing diagnoses than the physicians are. And if that's the case, then healthcare is going to become a lot more universal for people, because it's a lot cheaper to have AI make your diagnosis than have a physician make it. And like I said, we can't be sure that we're at that point yet, because we need this study to replicate. This is complex stuff. And even though this is a randomized controlled trial, it was a small one. But if this replicates, that's another example of markets driving down the price of healthcare precipitously and making it more universal. Okay, so I've talked a fair amount about how it's a matter of course, drive down healthcare prices. What about quality? Well, it turns out that different ways of paying doctors promote certain dimensions of quality but discourage others. Across the little arrow is gone. Oh well. Across the top there, what you've got across the x-axis at the top there is the headers are different ways of paying clinicians. So let me just start over here all the way on the left part of the screen with what we call per person or capitation. That's when you give physicians or a physician group a fixed amount of money per patient, with the charge to provide this patient all the care that she needs. This works a lot better if you do it for a lot of patients, and then the physician group or the health system has a lot of money. They end up pulling the risk. Well, but giving them a fixed amount of money to provide health care to all of these patients does a number of things. It performs really well. This system performs really well at reducing costs, because then every penny that the physician group or the health system doesn't spend on health care for these people is money they get to save. So they're not going to waste any money on unnecessary services. So they do a pretty good job of reducing costs by avoiding unnecessary services and by avoiding duplication. They will talk to each other, the physicians will, to avoid duplication, because that can be costly, and it's costly to them. It internalizes, this form of payment internalizes the cost to them. My sister-in-law had a brain tumor removed. Her insurance company, her health plan was Kaiser Permanente. It's one of these systems. It's like the only one in the private sector in the United States that operates on this per person or or capitation system. And she said it was wonderfully convenient, the way they coordinated care. Her primary care doc is in this office. Her specialists are down the hall. The pharmacy is on the other floor. If she had a question, they just go in there. She picks up her meds. So much more convenient than how my family accesses medical care. They also have incentives to avoid complications, because if they injure you with a medical error, you get a hospital-acquired infection in that system, it comes out of their pocket. So they invest more in avoiding complications, and they do more medical research and comparative effectiveness research, because they internalize the benefits of the knowledge that they gain from doing that. But when you pay them on this basis, they don't do, you don't get so much a choice of doctor or hospital or treatment, because if you've already paid the money to this group, you're pretty much limited to the physicians in that group. And it's harder to get second opinions outside of that group. And there is a perverse incentive for them to deny you necessary care, because at least in the short term, they save money when they do that. But there's other ways of paying doctors in hospitals and so forth. At the other sort of extreme, we have what we call fee-for-service payment. That's when you give a doctor or a hospital a separate fee for each additional service that they provide to you. And that is strong on many dimensions of quality. Unlike capitation over there, that creates an incentive for them to provide you all necessary care, because they make more money when they do it. Not like, they make less money when they provide you care over here. Over here, they provide you more care, they make more money, so they're going to do that. They're happy to offer you a second opinion. If they're getting a fee for every opinion they offer, you can go out and find third and fourth opinions if you pay them that way. You get a broader choice of treatment, hospital, and doctor, because if you're paying for each additional service, more of them will be willing to see you. But this form of payment is not so good on those other dimensions of quality where capitation is good. They don't have the incentives to do medical research that might show that what the doctor is doing is not beneficial, because then they wouldn't be able to collect more fees. They don't have the incentive to avoid complications, because, and a lot of people have a hard time believing this, but it is absolutely true in the United States, because we mostly have fee-for-service payment in the United States. A lot of doctors and hospitals can get paid first for a medical mistake and then paid again for fixing that mistake. They can get paid for providing low quality care and then get paid again because you need more care down the road. That's what fee-for-service encourages, and there are lots of examples of that I could discuss. There's the fee-for-service payment also isn't so good when it comes to avoiding unnecessary care. because they'll get paid for providing necessary care, but also for the unnecessary stuff. And I can talk about what the literature says about the vast amounts of unnecessary care that we get in the United States, I think as a result of fee-for-service, at least in part. And they don't coordinate care, because if they coordinate care and avoid services as a result, avoid duplication as a result, they get paid for duplication. They don't want to avoid duplication. And so fee-for-service is not so good on reducing costs. So by show of hands, after these descriptions of capitation versus fee-for-service, I mean, well, you might think, which of these two things, and I should mention, there are hybrids between these two extremes that get you a different mix of costs and benefits. But you might be thinking, okay, which of these is better? Which of these payment systems should people use? By a show of hands, who thinks capitation is better? Who might want to enroll in a health plan that uses capitation? Don't be shy. You're not going to get graded on this. Very few hands. What about over here in fee-for-service world? Lots of shy people in the audience, because even the hands that are going up are barely going up. Maybe it's because you're just not sure. Well, the wonderful thing about markets is, when government gets involved in healthcare, it basically picks one of those for you. Okay, so the Medicare program is all over here. And that's why there's one of the reasons why there's so much waste and unnecessary care in the Medicare program, why there's so many medical errors in the United States. And the government also encourages fee-for-service payment for the 56% of the population that have employer-sponsored insurance. Encourages, some people don't have it. The only places in the United States you're going to find pure capitation are basically two. One is in that plan that I mentioned, Kaiser Permanente, where my sister-in-law got her brain surgery. And the other one is the Veterans Health Administration, which is basically a government-run Kaiser Permanente, where the health plan, the health insurance plan, and the health system are all part of the same entity. It's like the British National Health Service, the Veterans Health Administration is, because it's literally socialized medicine. Government owns the means of production, and they use capitation. But the wonderful thing about markets is markets don't pick this for you. Markets let you choose one or the other. So if avoiding unnecessary care is more important to you than choice of doctor, you can choose this one. But if the reverse is true, you can choose that one. And it doesn't put people into plans that they don't like the way that we do in the United States right now. But the best part about how markets make quality healthcare more universal is no matter which one of these you pick, because a market system allows a level playing field between all of these different payment systems, each of them competes with the other, has to compete with the other on the dimensions of quality where they are weak. So that if I think that my Kaiser plan is denying me necessary care, I can just disenroll from that and enroll in Aetna, which is a fee-for-service plan, which pays doctors on that basis, and I get broader access to care than I did over there. Or if I think these premiums are getting too expensive, then I can go back over here to Kaiser. And the market disciplines both the health plans and the doctors, the providers, so that they all have to improve on all dimensions of quality. And this is what you get in the market system, rather than these huge gaps in quality you get when the government makes these choices for you. Government is making these choices for us right now, which is why healthcare in the United States is so of such dangerously low quality in so many cases. And another thing that markets do to make us safer and improve the quality of care is they certify the safety and efficacy of drugs. Now we have a government agency that's supposed to do this, the U.S. Food and Drug Administration. This image here is an advertisement that the Kaiser Permanente health plan put out. They're basically to say, not in so many words, but basically to say we beat the FDA at its own job. We found an unsafe drug that the FDA let onto the market. Anyone here old enough to remember what Vioxx is? Okay, well, two hands. Vioxx is a painkiller that came out about 25 years ago, I think it was. New class of drugs, COX-2 inhibitors, non-steroidal anti-inflammatory drugs. And it sailed through the FDA's approval process. The FDA approved it. They did multiple studies with thousands of patients, and they found that it does work. It does have analgesic properties, and so it goes out onto the market, and Merck is marketing this thing like crazy, and eventually millions of people are taking it. And some people started to notice, hey, wait a second, we're worried that this drug might be causing adverse cardiac events. But health and medicine are really complex, and just because you have a patient who took this drug and then had a heart attack, that doesn't mean the drug caused the heart attack. And even if you see this 5 or 20 times, that doesn't dispositively show that that the drug is leading to that outcome. In health and medicine, they're so complex. It's very hard to know if what the drug or the doctor did is responsible for a good outcome or not responsible for bad outcome. You need to do studies. Well, Kaiser Permanente is a health plan that, as I said, combines the health plan and a health delivery system, doctors and hospitals and all that, all down the line, and operates on the basis of capitation. And so they had the wherewithal, because they've been using electronic health records since the 1960s. They had the wherewithal and the records they needed to study whether Vioxx was causing these drugs, to get to the bottom of this question, whether Vioxx was causing these heart attacks, and they found out that it is. The FDA didn't find this out. The FDA was trying to do post-marketing surveillance. They couldn't generate the data. Markets generated that data all by itself, which is why markets, through mechanisms like Kaiser Permanente or similar health plans, could be providing even better quality assurance than the government is providing, and provide it as a matter of course. And the only reason we don't have Kaiser Permanente type plans littering the landscape, and why you may not know anyone in one of those plans, is because of government regulation. The government has done so much to block entry from those sorts of plans and tilt the playing field away from them with subsidies and tax penalties that it's very hard for them to get a foothold. And when they try to enter states like North Carolina, which they did a couple decades ago, they had to retreat because of the regulatory burden and because of those subsidies and penalties tilting the playing field. This is a map of what we call direct primary care practices. Direct primary care, you may have heard of this, it is a type of physician group that provides primary care where you pay a membership fee and then you get some additional, services, some additional amenities. These are basically nascent Kaiser Permanente type plans. And they are bumping up against regulation in every state in which they are trying to open and expand, because those regulations are treating them, first of all, they're limiting the number of services that nurse practitioners and RNs in those practices can provide, limiting their ability to make healthcare more universal. But also, the states are treating them like insurance plans and regulating them like insurance plans, which is basically an insurmountable barrier to entry for these sorts of innovations that could be out there making healthcare more convenient for people, promoting electronic medical records, making health insurance more affordable. This map is markets trying to break through the barriers that the government is putting in the way of universal healthcare. And I think this is my final bit on how markets make healthcare more universal. I mentioned tax penalties. The biggest distortion that the federal tax code introduces into the economy, aside from existing at all, is probably a tax preference that the federal government creates for employer-sponsored health insurance. The reason 56% of the US population has insurance through an employer, rather than insurance that we buy every other form of insurance, auto or life insurance or homeowners insurance, directly from the insurance company, is because of this huge tax preference, which is ultimately a penalty on people who want to buy health insurance directly from an insurance company. But what happens to access to care for the sick if you buy health insurance directly from an insurance company versus in a relatively free market versus this type of insurance that the government requires you to buy? Well, this graph shows that if you bought a health insurance directly from an insurance company in a reasonably free market, you are less likely to lose your coverage and end up uninsured than if you got it through your coverage through an employer. Why? Basically because employer-sponsored coverage disappears when you change jobs. And people change jobs about a dozen times by the time they turn age 52. And often they change jobs after they get sick. And so that doesn't happen as much. It happens too much. I think it happened too much in the individual market. It's what we call where you buy health insurance directly from insurance companies. But the market was still beating the government's horse, if you will, despite all the restrictions that the government put on the individual market and all the tax penalties that it put in place there. You were still better off in the individual market if you had a high cost condition, if you were in poor health, than if you had insurance through an employer, because you were less likely to lose your coverage and end up uninsured. Now, this next myth about the US health sector being a free market. How are we doing on time, John? I've been talking for a while.
5 minutes left.
5 minutes left. All right, then I will just do one piece of the US health sector as a free market. You'll hear this claim from lots of people, The Economist, state-run media in Canada. Well, then the OECD looks at advanced nations and says, how much control does government have over health spending in those nations? At the top is Germany, where the government controls 87% of health spending. And if the US had a free market in health sector, the government would control 0% of health spending, but instead it controls 85%, just 2 percentage points away from Germany, 5 below Cuba, which is a communist nation, and in a dead heat with France, Czechia, Denmark, and Norway in terms of government control over healthcare. And the government controls a larger share of health spending in the United States than in Canada or Britain, which have explicitly government-run systems. The reason that we spend so much on healthcare in the United States is because 14% of GDP is compulsory health spending that the government requires us to spend on healthcare. That's more than the bigger share of GDP than any country spends on healthcare, compulsory and voluntary in total. So this is not a free market. This actually makes Adam Smith very angry. And then, it's going to talk about what the United States does with all of these controls. We have basically every other health system that every other country has invented, every other form of socialized medicine, and even some that other countries haven't invented. The government, with all of those powers, does different things here, though. It hits the accelerator, making patients less price sensitive here than they are in other countries, which drives up prices, drives up overall health spending, and government also leaves us less free to make our medical decisions than in a lot of other countries. Less free to choose what medications we can purchase without permission from a government-appointed gatekeeper. Women in 100 countries around the world can buy birth control without a prescription, but not here in the United States. And government does lots of things to drive up prices, like how the so-called Affordable Care Act drove up prices for hormones and oral contraceptives by trying to make them free. The two main things that we need to do to fix this situation, to allow markets to make healthcare more universal, there's a lot of different reforms, but they fall into two categories. The first one is we have to change who controls the money. Right now, government controls 85% of the money in our health sector, forces us to spend it the way the government wants. We need tax reforms and entitlement reforms so the consumers control the $5 trillion we spend on healthcare in the United States, and then the system will serve them if they're the ones who are controlling the money. It will give them what they want, which is lower cost, higher quality, more universal healthcare. And then also we need to eliminate the barriers to lower cost, higher quality healthcare that government puts in place, both at the federal level and at the state level, that involves deregulating clinicians, deregulating health insurance, and a lot of other steps. And finally, the reason why this is so hard, the reason why it's so difficult to reform healthcare is because we waste tons of money, trillions of dollars on low value, wasteful, and even harmful healthcare in this country. But every dollar of wasteful health spending is a dollar of revenue to somebody, and that somebody has a lobbyist. And what this graph shows is that the health sector of the economy has spent more money lobbying Congress every year for the past 26 years. Since, I think, Carolyn and I started working together in the Senate, in the United States Senate, 26 years ago. And the health sector spends almost 6 times what the defense industry spends on lobbying Congress. And when they go to Congress, they will argue that if you cut this program, if you let this rural hospital close, you'll be denying consumers access to care. But really, what they're trying to do is they're trying to protect inefficient inefficient providers that could not survive in a market because they don't make healthcare more universal. They don't give consumers what they want. And that's what this graph shows. It shows that the hospitals that closed from 2015 to 2019, the rural hospitals that closed during that period, are the rural hospitals whose consumers were saying, hey, we don't like you anymore. We want to go to hospitals that are farther away. And so their admissions dropped precipitously, and that's why they were in dire straits. But did the hospitals go to Congress and say, our patients hate us and they're choosing other hospitals? Will you please increase our subsidies so that we can keep our low quality hospital in business? No, they go there and they say, your payments are too low. That's why we're going out of business. And if you let this hospital go under, there'll be 1,000 jobs lost in your district. And if you're a politician, that's a very persuasive message. So what we do at the Cato Institute is we try to find reforms that will deliver more universal health care, that will protect your right to make your own health decisions, and craft the messages that will persuade politicians to do the right thing so that we can all pursue that goal that we all share, which is universal health care. And with that, I thank you very much.
Excellent.